So similar to the previous talker, when I wrote these slides, I wasn't quite sure how to pitch things. I think I possibly pitched it at the wrong level. But having listened to the really interesting conversations today, there's lots of things I do actually quite want to talk about. So I might skim through the slides and then chat through some of those things towards the end. Um, my name's Steve Garratt. I am the imaging program manager at UK Biobank. And yes, I'm going to talk a little bit about how we gather and curate the data and process the data as part of our study. So a bit of background for those of you who aren't aware of UK Biobank. We're a large-scale health research study. We have a really wide range of in-depth information on 500,000 UK volunteers. They were recruited between 2006 and 2010, what we call the baseline study, where they conducted health questionnaires, health interviews, gave physical measures, and gave blood samples and urine and saliva. So very similar to what Our Future Health is doing at the moment. Since that baseline study closed, we have been continually building on that data. We've done a number of different sub-projects. So we've had 100,000 participants wearing physical activity monitors. We've done various genotyping on the blood samples that we collected, leading up to the very recent release of the whole genome sequence data for all 500,000 participants. And in 2012, we opened access to the resource, to the baseline data, to researchers, and that was quite wide access. Effectively, if you are a bona fide researcher doing health research that is in the public good, then you will be able to access this data. If you are looking for particularly sensitive data, then there might be a slightly higher bar to pass. But the idea is really that we want to share the information as widely as possible and then get the results back from that research in order to grow the resource even further. Then we can supply that data to further researchers to check and build. So we don't sell the data as such. We do charge an administration fee, which basically pays for the teams who review those access applications. But yeah, the data is freely given on the understanding that the results will come back and the results will be published in the open forum. So the imaging study that we're probably interested in more today was started in 2014. With the goal of imaging 100,000 of those 500,000 participants. We're actually now, we've recruited over 80,000 of those participants. And as the initial imaging comes to a close, we're just starting doing repeat imaging in up to 60,000 of those 100,000. So we'll have some longitudinal data within the study as well. And we actually did a COVID repeat imaging study back in 2021, and I'll talk a little bit about that later. So the really important thing I think about UK Biobank is the breadth and depth of data. So we've spoken about all these different data sources that are available out there, and Biobank really has a phenomenal amount of data on a large number of participants. And that means that we're able to do lots of statistically significant research. And so the chart I've got here, it's a very simplistic one really. This is showing a comparison between mortality risk and systolic blood pressure. And this is in 5,000 participants. And you can't really read a great deal into that. There's no obvious trends, perhaps a suggestion in most ages that there's an increasing risk of mortality with higher blood pressure. If you increase the number of participants up to 50,000, then you start to see a lot more of a pattern there. But there's still a high degree of uncertainty in that data. And actually, if you look, there is a suggestion that very high blood pressure in our eldest participants might actually be beneficial, which doesn't really ring true. And it's only really when you go to 500,000 participants that that picture becomes extremely clear. And I guess the point I'm trying to make here is data is noisy, and the more data you have and the better described that data is, the better research you're able to do. So UK Biobank imaging, we have a number of modalities. So we do MRI of the brain, of the heart, and of the abdomen. We do DEXA imaging for bone density and body composition, and we do an ultrasound of the carotids that give us a measure of cardiovascular health. For the repeat imaging, we're also doing OCT scanning for a measure of retinal health. And as well as doing this, all of our participants do a repeat of the baseline study, so we get a second time point for all of the health questionnaire data and interviews, and we get a further blood sample. I want to focus a little bit on the brain imaging today, just for simplicity. There's an awful lot I could talk about, but this is a fairly standard T1 weighted image of the brain. The more critical of you might think that this is a little bit blurry, but actually this isn't a picture of a single brain. This is an amalgamated image of 5,000 brains that were collected in the Biobank study, and it's just really to show what's possible when you're able to have standardized images. And it's an incredible challenge that you face trying to do this sort of research with routine clinical data. You don't have these benefits, and it is a massive benefit to be able to standardize the images as we are. So we have 4 sites across the UK. There's one in Reading, one in Bristol, one in Newcastle, another in Cheadle. But they are all extremely similar sites. If you are plonked into the MR control room in one side, you would struggle to know where you were. They all have the same scanners, the same equipment, the same head coils. We run the same protocols with the same parameters. Our radiographers aren't allowed to change very many things at all, which is very alien, I think, to well, certainly to the light in this room, who will be very prescriptive about precisely what they want to see in an image for radiographer captures. We have SOPs for standardized training for all of our staff. So the images are, as best as we can possibly manage, very alike. But there are still differences. And I think understanding those differences and being able to account for those differences is really important. So just in Biobank, we look at subject-specific differences. So age, gender are the obvious ones, but even going down towards head size, and being able to account for head size is really important when you're trying to standardize images. We look at differences in the acquisition. So even though it's the same equipment, it's not the same equipment. There are 4 different scanners. They might be the same manufacturer, but they are different. Over time, we have coil changes. We have to have magnet ramps. There's all sorts of things, and every time something like that happens, we have to record the event because it changes the underlying data. You have things like head motion. So you have some participants who can't lie as still in the scanner, and understanding that and being able to account for that motion is really important. Where the table is inside the scanner, where your head is in the ball, is important in understanding the results. You can then start getting to all sorts of more complicated confounds. So how these different things might multiply together in different ways to actually accentuate differences in the data. And then the date and time, again, it's been spoken about today, and the dangers, if you like, but they are really important. Our scanners heat up through the day, so the results at the end of the day are slightly different from somebody who's imaged at the beginning of the day. So understanding the time is very important. Understanding what time of year might be important, and certainly understanding in terms of how old is the scanner, and what changes have occurred over time is really important. So we have some collaborators at Oxford who have developed a pipeline, and it's continually developed over 10 years to again further standardize the data using those confounds. So they do some automated quality control checks. They transform the images, and that includes defacing. So again, we spoke before about a 3D model of the head. You can recognize somebody. So all of our images are defaced as part of this process. And then ultimately, we derive a whole host of variables. Around 3,000 separate measures of structure and function are taken from our data. And again, they are provided to researchers. So if you want to do research into brain health or anything to do with that, you don't necessarily have to analyze the images. You can take the measures that have already been produced and do your research on those. As I said, this pipeline has been going for around 10 years, but it is still developing and will continue to develop, and we will start using a lot more AI techniques, and certainly some of the other modalities are doing some really interesting things with AI and providing that data back into Biobank. So yes, so this standardization, really, this pipeline that helped produce this image is really critical for us and allows us to do research that really isn't possible anywhere else in the world. And I think the COVID study that I spoke about really briefly earlier is a good example of this. So in 2021, well, 2020, all of our sites closed due to the pandemic. We had a particularly vulnerable age group. All of our participants at recruitment 15 years ago were aged between 40 and 69. So we regularly have participants in their 80s coming for imaging visits. So we closed the sites, but we got some funding to do a study into COVID. So we already had thousands of data sets to start with. We invited participants who we knew had COVID. Again, we have linkages into medical records. We did a serology study where we sent out tests to our participants. So we invited participants who we knew had COVID, and then a control group of people who, as far as we knew, hadn't had COVID, and they had repeat imaging. And the paper was published in 2022, where they identified small but significant loss of grey matter and tissue damage in the brains of participants who had COVID. And without the standardization, without those corrections, without the number of participants we were able to scan, you just wouldn't have been able to say confidently that that was the case. So for us, this standardization, the fact that we do this so carefully is incredibly important. So, as I said earlier, all of our data is made available to researchers around the world, whether they are commercial or not. This is a little bit out of date, but we have over 7,500 publications from 30-odd thousand approved researchers. Those papers have been cited over 200,000 times. And we have researchers from over 90 different countries accessing the data. And I think this is the biggest area of risk, if you like, but it's also the biggest area of potential. So by allowing researchers from around the world to access this data, it's already uncovering some amazing information, amazing research. We are starting to get real results that are feeding back into the NHS from allowing this. And I think it's really key that we continue to do this, but we have to do it in a very careful, controlled manner. And I think, as we mentioned before, there was a recent article about insurance companies getting access to UK Biobank data. And I think as far as we're concerned, and I would argue we could have done a better job of explaining this being utterly transparent, but they are no real different from any other commercial organisation. If they are doing health research that benefits the good of the country, of the participants, then there is no reason for them not to have access to the data. But this is pseudonymized data. It certainly isn't individual health data that you could pinpoint somebody and start upping their premiums, but that is how it is being spun. And I think we do need to be extremely careful with the narrative, with the discussions, with the transparency. And I think the idea of identifying a group who can go about educating the public generally, but it is really important. I think it is all about education. So what have we learned? How might this help you? So again, I don't think any of this will be of any surprise, but Biobank, we have the largest medical research study in the world by far, with the largest imaging study in the world by far. We gather around 20,000 participants per year at the moment across the 4 sites. That is dwarfed by the amount of data that's collected in the NHS every month. So within the NHS, you'll do 300,000 MRI scans, 500,000 CT scans, 800,000 ultrasounds, nearly 2 million plain film X-rays every month. And yeah, this is clearly very different data. Clinical data is for a very specific diagnostic purpose. It is not really comparable. But when you have that volume of data, there is comparable information in there. There are comparable data sets. You will be able to do really meaningful research if you're able to understand that data. And I've heard metadata being mentioned several times. It really is critical, and it's a little bit cheesy, but if you want to find the treasure, you need a treasure map. You need something to tell you what you are looking at and enable you to filter out the noise. But it is possible, and I think it should be a real goal of everybody to try and access that data. And all of the things that have been mentioned about privacy, anonymity, protecting your patients is absolutely critical here. But if you can get that data and you can get it in a standardized format, I know we've been 30 odd years since digital systems were introduced into GP practices, and the proliferation of data hasn't slowed down since then. But if we can find a way of standardizing these approaches, or gathering this data into a standardized pool where researchers can access it, then I think that is incredibly important and valuable. And that really brings me on to the final point in terms of access. So I think the thing that really sets Biobank apart is the fact that we are allowing access to the data from such a wide range of researchers, and unlocking access to that data to researchers wherever they may be from. And I absolutely agree that the commercialization of NHS data is a thorny subject. As I say, Biobank have taken the easy route, if you like, by not charging for it. None of our participants expect to be paid. They gave their data freely to be used for medical research to improve the health of future generations. That was our strap line. But public confidence is incredibly important. So for Biobank, if we had a large data leak, I mean, even the article about the insurance company, it drove people to withdraw from the study. If something happened that made our participants withdraw, and they can withdraw at any time, then it would effectively end the study tomorrow. So it's incredibly important that data that we release is anonymous. I think we need to explain the risks to our participants when we are sharing their data. I think when we are reviewing access requests to that data, we need to be diligent. And then in terms of the actual agreements we have in place, the data sharing agreements we have in place with researchers, it needs to be really clear what they are able to do with the data, and the fact that they need to be open in publishing the results and returning that data back to us. But I think you have an amazing opportunity here to really drive forward the research that is possible. So I'll finish with a few acknowledgements. So from our funders, I know primarily Medical Research Council and the Wellcome Trust, but also more recently for the repeat imaging, Calico and CZI. Our collaborators for today, a lot of the work you've seen on the brain images was done by the Oxford Centre for Functional MRI of the Brain. And finally, our participants. So as I say, 500,000 participants who give up their time, who give up their highly personal data for absolutely no benefit. You know, they come for an imaging visit. It lasts about 4.5 hours. People travel hundreds of miles to come and do that. And literally all they get is a thank you and perhaps a sandwich. And they astound me all the time. Thank you.